Okay, anytime you're ready.
Okay, thank you. All right, good morning, everyone. And thank you for joining us. Today's agenda of the Pharmacist Reimbursement Working Group has two topics. The first one was the definition of healthcare provider, and I had talked to some people from MDH and was hoping to see that they were here. I don't see their names yet. So maybe we can make that the second topic. And then the other topic is practice settings and challenges for billing in certain practice settings. We have received some documents from working group members, and they either have been posted to the work groups page on our website or will be soon. We try to do that as soon as possible, and things are considered public. We want to be as transparent as possible. A few housekeeping reminders. Please stay on mute if you're not speaking, and it's helpful if you raise your hand to speak so that we can keep things in some kind of order. And we are recording the session. If you are not registered to speak and have not received a link that allows you to speak, you can put a note in the chat and we can arrange that at the end. Senator Beidel, do you have any preliminary comments?
Good morning. No, not at this time. Thank you for arranging the meeting.
Thank you. And we're glad you could attend. So since I do not see an MDH person on yet, let's go ahead with the practice settings. And I believe we have Jessica Wiltz signed up to speak.
Yes, good morning, afternoon. Yeah, my name is Jessica Wiltz, and I'm a pharmacist and the director of managed care for Albertsons Companies. Albertsons Companies has over 1,700 pharmacies in 33 states and the District of Columbia, with 57 pharmacies in Maryland operating under the Acme and Safeway banners. We currently bill in several other states for medication administration, testing and treating of flu and strep, and consultations to provide hormonal contraceptives, statins, smoking cessation products, and UTI and cold sore treatments. Numerous studies have shown that patients have increased access to pharmacists in the retail pharmacy setting compared to other healthcare providers, and that including pharmacists as providers lowers the overall cost of healthcare. In 2017, Senate Bill 363 was passed and instructions were provided by the state on how to get set up to bill Medicaid for prescribing hormonal contraceptives and self-administered contraceptive devices, which involved getting new NPIs for each pharmacist and each pharmacy, in addition to the NPIs that they already have, enrollment with Medicaid of each pharmacy as a group pharmacist prescriber and affiliating with at least one rendering prescriber, and the pharmacist enrolling as a pharmacist prescriber renderer. This process requires additional steps that other states do not currently require. And this was just for the fee-for-service side, which only covers a portion of all patients in Maryland with Medicaid. So when we attempted to get credentialed by the MCOs for medical billing, we were denied, and it was explained that pharmacies cannot bill as medical providers, even though the new law allowed for it. If the MCOs were to recognize pharmacists as providers under medical billing, we would then need to enroll each pharmacy and credential each pharmacist with each of those plans. So unfortunately, right around that time when we were getting to that point, COVID hit and our resources were redirected to handling billing for COVID products. But we're now at a point where we would like to pursue the billing setup, particularly to be able to increase access to patients in the community setting, given the recent increase in requests for family planning services. I appreciate your time today and your consideration of community pharmacies and pharmacists as this work group continues to discuss the options and requirements necessary for the reimbursement of pharmacist services.
Okay, thank you. Does anyone have questions about that? Anyone on the working group? Okay, I know we had a request for presenting slides. Are you ready to go? I think it was Magali.
Yeah, I'd be happy to. Again, Nikki and I confer a little bit, and I thought that sometimes visual things make it more clear than us explaining. So we thought that we could share the slides, and we'd be happy after this, Mary, to provide it to you, to be or submit it for the record.
Ms. Rodriguez, I can make you a co-host and you can share if you like.
Thank you so much.
Yes.
So let me make sure that I can do that. Hold a second. Of course, I'm showing you everything that has nothing to do with it. So here we go. Can everyone see them?
Yes.
Yes.
Of course. Oh, hold a second. There we go. Okay. So what Nikki and I wanted to do was, I don't know why it continues to go to 48, even though I'm trying to make it go to number 1. Before we get started, what we wanted to do was really give you a little bit of a quick sense. We're not going to go through everything because we don't have time, Mary, so don't get scared. But we wanted to focus on 2 things today. I wanted to first focus on the ambulatory care setting because I think that's what also is causing some confusion. And so for everybody to understand, that is a pharmacist that is working in an outpatient clinic. So think about people that are providing care in a nephrology clinic or in a primary care clinic, and also pharmacists that may be working in primary care clinics. And we have provided in the link that we gave you a lot of evidence, right? Clinical evidence that shows that when a pharmacist is embedded, when a pharmacist is working as part of the team, 2 things happen. One is we improve care in collaboration with the other healthcare providers, but we also reduce unnecessary healthcare costs. And I think we gave you plenty of evidence, so I'm not going to get a lot into that. But what I wanted to do was kind of reset that what we're asking for, and we wanted this group to consider, is not expansion of the scope of practice. So everything I'm going to talk about and Nikki's going to talk about is things that currently under the scope of practice of a pharmacist we can do, right? The things that we can do. And also show you that we're also not asking for a special codes to be developed for pharmacists. We're not asking for anything special except for the health plans and Medicaid to grant pharmacists to be a healthcare provider and grant them the ability to bill for those services under the current codes, okay? So they already have it, they have the codes, we understand. So there's no question in our mind that we don't have to go to credentialing system like any other healthcare provider. We understand that. So it'd be the same thing, it's just recognizing that pharmacists have the ability to do certain things that will benefit the patients, benefit the health plan because it reduces unnecessary healthcare costs and improve care, improve satisfaction. So we just want the pharmacist to then be added as a healthcare provider. So I just wanted to set the stage. So what does that mean? Well, I'm going to focus pretty much, and this is what I said, it's again, not the scope of practice, it's really billing, and it's not even billing, but it's payment for the services that are recognized. We know now that the potential payers that are there are Part B, as in boy, Part D, Nikki's going to talk more about the Part D, which is the prescription benefit part for Medicare, state Medicaid, and like it was alluded by Jennifer, and I hope that Mindy later will talk to you guys about the experience in other states. Other Medicaids in other states are paying pharmacists for this. Pharmacists are providers, they're billing for it. Private sectors, there are other Blue Cross Blue Shield, Aetna, or a lot of other, United, many other private plans that are doing it in other states like Ohio, California, Florida. And again, a value-based contracts. I'm not going to get a lot into this, even though we're participating in Maryland in the value-based, because that is more of a different kind of billing. So I just wanted to stick with what is at stake here, which is really that Medicare Part B, or that evaluation codes that many of the health plans use. The biggest issue here is that currently the question last time is, why can't you guys do it? Why can't you bill for it? Well, we cannot as an independent provider, because Medicare Part B in the Social Security Act does not recognize pharmacists. They recognize nurse practitioners, clinical psychologists, midwives, a lot of other people, but pharmacists have not been able to be named in the Social Security Act as a healthcare provider that can, using the NPI bill for services. So I just wanted to set the stage for that. So what are we doing now? Because we're not recognized, the way that we are integrating ourselves and contributing to healthcare is different if it's institutional and non-institutional. So Nikki is going to talk a little bit later about the skilled nursing facilities, and I'm going to focus the next set of slides in the non-institution. So again, it's the outpatient setting, and that will include ambulatory care clinics, but also could include pharmacies, community pharmacies that have this kind of arrangement or have these clinical services provided there. So the biggest issue right now resides on what is called supervision. What is the supervision that is going on the Part B right now? The very strict guidelines that says pharmacists can bill under Incident 2, and I'm going to explain that in a minute as simpler as I can, but it has to be under the supervision of a healthcare provider that is recognized under Medicare to do that. So in many cases, it could be a nurse practitioner or it could be a physician. And so they have to be, there are certain regulations. Sometimes it says you have to be in the same place, in the same building. Other times it says that supervision could be general supervision. So many pharmacies in many states will have this general supervision under a protocol. So they develop an arrangement with the physician. There's a collaborative practice, there's a protocol, or other times there's different arrangements for this supervision. So most of the bills that you see are going to be what we call the HIP or the CPT codes. CPT codes, the common procedural terminology codes, those are usually managed by AMA, and they already are set for all healthcare providers, and that's what's used to bill for. The HIPS codes are mostly managed by CMS and tend to be more for facilities or services that are provided within a facility. So the biggest issue continues to be what kind of Incident to what kind of the evaluation codes can pharmacists use depending on where they are. So if a pharmacist is located in a pharmacy or in an ambulatory care setting, many of these bills cannot be used or used only in the level 1, again, because of that lack of provider recognition. But we recognize that pharmacists are able to do much more than that, right? They're able to build in other codes and other higher levels if their contributions are recognized, and many states do that. They're recognized to do that. Right now, what we do is this Incident 2 that I was talking about, but we also have seen pharmacists being able to bill for transitional care codes, chronic care codes, annual wellness visits, and diabetes self-management training. Again, because of time, Mary, I'm not going to get into a lot of that, because a lot of these codes also tend to be a bundle payments, all right? People bill just a general amount for everybody that takes care of that.
Yep. And Magali, we'll also have time at the next meeting to get into coding more.
Perfect.
We don't need to do it all today.
Okay, perfect. So again, the biggest issue and the issue that we have at stake is this evaluation and management, all right? That's the ones, those CPT codes and those that are not hospital-based but ambulatory care-based. So again, we know that this is really the backbone of how physicians and other healthcare providers bill for it. And you all know that different levels of complexity, is that right? There are different levels of complexity. And with that, it comes, again, the payment amount. So depending on how the level of complexity is how much people get paid. This might vary depending on what region of the country you are, or it may vary for private health plans that may pay differently, different amounts. But the issue here continues to be that right now, the only way that a pharmacist can bill, even if they work with a patient for an hour, even if the physician delegates to them a lot of functions, even if they have the ability, the capacity, the training to work, it's only the 99211. They cannot do anything else because of the lack of recognition by all payers of the pharmacist being a healthcare provider. So again, that's the 99211. Again, it usually is, again, the incident 2 is under the physician's NPI. So the pharmacist, even though we have NPI numbers, we can't directly bill. So the challenge here is that our colleagues, physicians that have us working in the practices, working with them in the ambulatory care clinic, get very frustrated because they said, we're paying you, we are reimbursing you for a more higher level of care, but we can only recoup the 99211, and that's not enough for our practice to be able to do this consistently, for our practice to sustain having a pharmacist engaged at this level, because we're not being compensated for the level of care that you're providing. So again, many of our physicians really advocate for us to be able to be providers so they can have us in the practices and working with them. So again, that is pretty much what we're able to do, the 99211, again, under the physician. And again, as you see, the level of reimbursement really does not compensate for the level of service that the pharmacist is doing. Again, these are some of the requirements. I'm not going to get to it, but I will give it to you, Mary, to put in there. But again, there's certain requirements that we're not saying that we're asking for anything special. We're not asking for the health plans to remove any of these, but the challenge that we're having is the ability for us to directly bill and the ability for us to bill at those higher levels. So that's kind of what I wanted to highlight in here. And then when Nikki comes, we can talk about other type of billing later on, Mary, as you stated, but that is the biggest issue. And that's what we were trying to get with the legislation. Two parts: recognition as a healthcare provider, and secondly, pharmacists to be added based on their expertise, based on their impact as providers, with the ability to bill at higher levels as their own provider. Thank you for your time.
Thank you. That's interesting, and I look forward to getting the materials so we can share them all and look at them at leisure.
Yeah, thank you. Any questions for me about this particular topic? Again, there are other type of billings, there's other type of value-based, but I didn't want to get into that right now because those are not really probably what is the biggest challenge. Is really the more direct service.
Okay, thank you.
You're welcome.
And then you said, Nicole?
Yep. Thanks, Mary. I will go next as long as you can hear me. Magali, if you want to maintain the slides.
Yeah, I am going to take it to the part D.
Perfect. So good morning, everyone. And thank you all for jumping on this call and listening to our discussion on pharmacist-directed services. So Magali eloquently just articulated a lot of the Medicare Part B aspects. So again, I'm going to switch to Medicare Part D, as in dog. And this program is an additional benefit in addition to the products or prescriptions through Medicare Part D, but it's a service and a program that was started back in 2006. 2006. There's been a huge evolution with the Medicare Part D program. And so I'm going to focus a little bit on what this service entails, why it's important, and how there are unique codes and billing codes for this. So Magali, I'll have you go to the next slide. So the American Medical Association identified CPT codes. So we actually were so excitement in the pharmacy community when we got our own codes, which really articulated the work that pharmacists do as part of the healthcare team. And so you'll see these codes 99605 through 99607. And they're billing codes based on 15-minute increments, and depending on if this is initial visit or additional 15-minute visits. And there was a lot of discussion about the definition itself. So medication therapy management services describe face-to-face patient assessment and intervention as appropriate by a pharmacist. And this is provided to optimize the response to medications or to manage treatment-related medication interactions or complications. So this service, again, under Medicare Part D, was really enacted to engage older adults, Medicare beneficiaries, to optimize their medications, as well as to educate them about medication-related concerns and needs. So the program has evolved through the years. Next slide, Magali. And this service is administered by prescription drug plans, PDPs, that work with CMS, and they design their program every year. And there's a lot of nuances to the program design that I won't get into details with, but basically PDPs can contract the delivery of MTM services themselves, where they can deliver it in-house, or they can cooperate and work with licensed and practicing pharmacists. So I'll give you a for instance. I am a pharmacist embedded in a geriatrics practice. Our practice spans across the ambulatory care setting and the nursing home and assisted living facility setting, as well as the home-based primary care setting. We have contracted with particular plans through a platform called Outcomes, for instance, and they flag when our patients who are allocated to our provider's NPI become eligible for this MTM benefit. And we've seen that this is really, through our experience over the last year, this is the first time we've been doing this in this kind of mixed patient population, but also practice population. And what we've definitely seen, we've gotten feedback from our older adults and those who care for them, is it helps to answer additional questions outside of those visits that they already might have with their medical team, or even us as pharmacists. Because for those of you who know older adults or care for older adults, medications are constantly changing, and there's a lot of unmet needs when it comes to medications. And so in particular, this Medicare Part D MTM benefit requires an annual comprehensive medication review. Though some plans may choose to do more than just one annual comprehensive medication review. They also can do quarterly targeted medication reviews. And afterwards, the individuals, the beneficiaries, the patients are provided a standardized summary, which includes a medication list, as well as a medication action plan and a cover letter on how to get a hold of that pharmacist that work with them, because it may not be a pharmacist they're familiar with, but hopefully it is. And all of that is sent to this beneficiary within 2 weeks of this service. And then any additional action items are shared with the healthcare provider. So there's been a lot of attention given to the evolution of this program, and even additional enhancements to this program in certain patient populations. Next slide, Magali. So what's important to note here from a payer perspective is these CPT codes cannot be billed under Medicare Part B as in boy, like Magali mentioned, but CMS allows Part D plans to accept these CPT codes for these MTM services. And so what's also important to note, I was talking with a colleague of mine in California who does get paid by the state for these CPT codes in the post-acute long-term care setting, the nursing homes and assisted living. So MTM CPT codes can be used in Medicaid and private sector plans if the payer recognizes the code. And so it's a nice segue to a population that's sometimes forgotten about is our post-acute long-term care setting. So next slide, Magali. So in the state of Maryland, very sensitized, we're focusing on Maryland today. We know that there's currently about 230 nursing homes, upwards of about 30,000 beds. And we know that our nursing facilities or nursing homes have a lot of transition in the individuals who reside there. They can be short stays, which could be on average, typically about 28 days is what I was given some statistics for, or they could be long stays, greater than 100 days. On minimum, they get at least a monthly medication review conducted by a pharmacist under a facility contract. But I can tell you, due to the acuity and medication burden of this population, there's a lot of unmet needs, and we'll talk a little bit about those in addition. But typically, that once a month medication review is paid for by the facility contract. In assisted living facilities, we worked very long and hard to get regulations to, again, look at medications. So medication regimen reviews are conducted at least every 6 months by a licensed pharmacist, but we found by doing some of our own work that it's typically done quarterly. The payment mechanism is highly variable. Sometimes it's under the facility contract, sometimes there's other mechanisms, but it gives an opportunity potentially to have more presence of pharmacists, because what we do know is that our older adults in these care settings and nursing facilities are considered institutionalized. Assisted living facilities are considered community-based programs. So they're quite dichotomous in terms of opportunities to bill as well. That there's advanced care planning that some pharmacists may be providing or could provide if they could get reimbursed for it, especially because of the medication-related concerns. And there's been a lot of concerns regarding agents like psychotropics or antipsychotics. Discharge planning is a huge unmet need. So looking at that as an opportunity for pharmacists to become more involved. And we know, and I conducted many vaccine clinics in our long-term care facilities, that there is now opportunities to have pharmacists bill for those codes, but can't bill for the education that we provide to residents when it comes to vaccine, because not everybody will get a vaccine. And then an emerging opportunity from a medication safety perspective is pharmacogenomics, which again may have Medicare Part D or Medicare billing codes. So these are just some of the opportunities I just wanted to bring to the attention of you all in terms of another care setting where pharmacists are practicing like myself. So with that, Magali and I will open it up to questions and really appreciate the time to share with you some practice perspectives.
Great, thank you. Are there questions? I see Allison Taylor has a hand up.
Thanks, Mary. Thanks, Magali and Nicole. First of all, I want to say Kaiser. So I'm Allison Taylor with Kaiser Permanente. Kaiser employs clinical pharmacists and has had a lot of success with that. So, definitely support the goal of expanding what clinical pharmacists can do. Apologize if this is a dense question, but Nicole, if you could provide some more clarification. There's a lot of discussion about Medicare Part B and D. How does that, and so I can see the issue there. Can you say again how this relates to the commercial market and how the state can address this problem?
Yeah, so at least I can speak to if pharmacists could be identified as providers, as Magali mentioned, under Medicaid, we potentially could use similar codes to MTMS codes. And that's what other states have done for doing these type of face-to-face comprehensive medication reviews or targeted medication reviews. Those aren't currently reimbursed by Medicaid. Does that make sense?
That makes sense for okay, so Medicaid, what you're saying is Medicaid could follow what Medicare is doing.
Correct.
And then, okay, so that deals with that. And then in the commercial market,
could also be a very similar thing to that as well, Allison, is using consistent codes, service definition, and for the commercial market as well.
But can I add something?
Yes, please.
And I know I saw Mindy Smith in the call, and Mindy has experience with other states that had done what we're trying to do in Maryland. And the other thing is that for many other health plans, Allison is not just limited to the MTM codes, because there's recognition that pharmacists can perform other functions, other services that already the health plan pays for, all right? So we do know that the health plan already has codes and has services that beneficiaries get. And so what they have done is recognize, okay, pharmacists have the training and the ability, added them as providers and allow them to use many of these codes that I was talking about, many of these E&M codes, because they just added them as a provider under that. Because we can do a lot of other things that is not just hypertension management, diabetes management, cholesterol management, many other things. So I just wanted to highlight that is not only MTM codes, but really it is a broader inclusion, including those. So
Thank you. I do want to note, of course, the state does not regulate Medicare. I realize we're looking at it as instructive for the other markets.
yes.
And as I said, we'll get into coding. We can do a deeper dive next time. But thank you for the presentations. They were very informative, and I'm glad we had a chance to hear them. I do see that Trisha Roddy from Medicaid is in as a panelist now. So perhaps now we can move the topic to the definition of healthcare provider and what we've heard about how that impacts payment.
Yeah, so Mary, I'm happy to give kind of a brief summary of how Medicaid looks at these types of coverage decisions within our program. So essentially, the first thing we look at is scope of practice. And so we want to make sure that it's within their scope of practice to bill for these types of services that we're discussing. I know these are just examples, but that would be the first question we would have. Generally, we like to bring not just the Board of Pharmacy to the table, but we like to bring the Board of Physicians to the table in these types of discussions, just to understand all perspectives of the various providers who offer the service. And then, of course, we look at both the federal rules and regulations of what they require in order to draw down the federal match for authority. And then, of course, we look at if it's a new service that's not generally offered by other providers. Obviously, there's a fiscal cost to covering the service, so we have to get budgetary authority for it. And then kind of lastly, the one thing that I do want to mention, when we're covering a service, when we're talking about our health plans, we are covering the service. It's up to them to make sure that they have appropriate provider networks. And so that doesn't mean necessarily that they have to contract with all providers to provide the service. They can make sure that they have appropriate access for their enrollees and develop their provider networks. They don't have to contract with every provider. So that definitely comes into the equation that is left with the managed care organizations. So Mary, that kind of gives sort of a high level of how Medicaid views these types of coverage decisions.
Thank you. I'm glad you could attend today and address some of those questions. Are there any questions from the work group members?
Yeah. Hi, this is Howard Half with the therapeutics team. Pleased to see everyone. No, so I apologize for arriving a little late. And in terms of the coverage for these services, is there a distinction between what's done during a national health emergency to address critical issues in terms of delivery of care versus what's done in the usual order of business?
Well, Of course, Howard. I mean, I obviously know that the federal government said for pharmacists to give the COVID vaccination, it didn't care what the state laws were, that the federal laws kind of trumped and allowed pharmacists to provide the vaccination during the pandemic. It's my understanding that they are going to continue that authority beyond the federal public health emergency. But that's an example of where the federal government stepped in and said, this is going to trump any state laws or board requirements.
Right. So how does that impact payment through Medicaid or through commercial payers then?
I can't speak for commercial, but for Medicaid, we covered it.
I know we have representatives of several commercial carriers on, and I'm sure we'd be happy to hear from you on any of these topics. I see Magali, you have your hand up.
Yeah, my question is for Tricia. So we do know that in many other states, Medicaid. So what happens with Medicaid, and correct me if I'm wrong, is that Medicaid can add what services that they will require the MCOs to provide to the beneficiaries. So you guys said, okay, beneficiaries in Maryland from Medicaid will have these services. So if you decide that medication therapy management, let's say for example, is something that you want your beneficiaries to receive, then the MCOs, I understand the MCOs will define and find a way to provide it. They create their own network, but it's something that is delineated centrally from Medicaid. So the question that I have for you is, what would it take for Medicaid in Maryland to recognize, like many other Medicaid programs have done around the nation, that pharmacists could be healthcare providers, could do these, and that medication therapy management, diabetes control, or certain things should be done for the beneficiaries like other states have done? What do we have to do to get that process going?
So, I think each one of these we'll have to take back and kind of take a look at, but medication therapy, obviously there's codes. It's sort of it's a new service, and there will be a fiscal cost associated with it. So that one in particular, it will require a budget initiative, and money will kind of be that will be the driving factor of our ability to cover that.
So does that process require legislation, or how is that even started to be evaluated by you guys and to decide if it is possible and the cost? Like, what is the process?
Well, it happens many different ways in terms of us. Sometimes there's a report asking us to generate what the fiscal costs will be for the service. And through this work group, this could be a recommendation that comes out of it for Medicaid to develop the fiscal costs associated with covering this service, and to report back to you all. So that's an example of how some things work in Maryland. Generally, I think that step needs to occur before legislation happens.
Thank you.
Okay, anyone else have questions, comments? Any of our commercial carriers or MCOs have questions or comments? I think Kathleen Lochran, you have your hand up.
Yes, good morning, Mary. Good morning, everyone. Thank you for the opportunity to speak. I just wanted to add to Tricia's comments regarding the question around process and how determinations are made. I guess I want to be somewhat clear. I think for some of the participants on this work group and other interested parties, because there's often some confusion or blurring of the lines between commercial and Medicaid. It is important to understand that the Department of Health and under their Medicaid program makes decisions about benefits and determines cost value of those benefits. So it is not ideal or desired to have this decision or determination made by another agency that does not have the knowledge of the Medicaid program. I appreciate that the conversation has come to all of us in this fashion through legislation, but it's really important to note the policy distinction, and I think that the agencies do, but I just want to stress that for all the stakeholders. These decisions that are being made, be it Medicaid, Medicare, commercial, cannot all be made under one regulatory body. There is a separate and distinct regulatory body charged with the Medicaid program. And to Tricia's point, it is in large part because there is a state fiscal impact when making these decisions. And so I just want to stress that while it's good to have the knowledge and the conversation as a group, we are going to have to separate this when action or recommendations are being made and be very distinctive between Medicaid and commercial. Thank you.
So what I'm hearing, and feel free to correct me if I'm off base, is that based on what the bill said that created this work group, and what I'm hearing from Tricia and Kathleen is that this group could make a recommendation that Medicaid evaluate the fiscal costs and make the decision. But it would be Medicaid's decision to make, but we could recommend that they consider the costs and consider the benefits and then make the decision, and the recommendation could serve as a springboard for that. Because we certainly don't want to take on anything more for Medicaid or Medicare or any other agency than we are charged with doing. But I think that was part of the charge in this work group. Okay, Senator Bidel, I see your hand is up.
Thank you. Just to add to the discussion, this group can make recommendations and the legislature can decide to put bills in, and the evaluation would happen as a result of the discussion on those bills. So whether or not funding is available to Medicaid through the Budget and Tax and Appropriations Committee, whether, depending how the discussion goes, just because Medicaid makes the final decision doesn't mean that we can't put a bill in requesting that this be done. And then the process kind of begins with the introduction of a bill.
Yeah, I wouldn't dispute that. I just, it's nice to know the fiscal costs before generating legislation.
Yeah, and I think my point, Senator Bidel, and I respect what you have to say in the process, obviously. I guess I was trying to be more clear that this is something that is regulated by the Medicaid program, not by the MIA. So whether or not you choose to do this in the Medicaid space, it's something that would have to go through the Medicaid program, not through the Insurance Administration. It's not a benefit or a mandate on MCOs that would be properly regulated in the commercial market.
Thank you.
Okay, thank you. I appreciate all the comments. Matt, I think you have your hand up.
Thank you, Mary. And thank you for gathering all of us. as you might have noticed, some of the commercial carriers are not on today. We have a bunch of people are out on vacation. And I think there's a couple of folks in the pharmacy community who aren't here too, including Aaliyah, who I think we had talked in the past, and Aaliyah had mentioned at the last meeting that she was going to send us over a list of CPT codes and other statutes from other states. And I know that the commercial carriers are eager to sort of dig into those and try to sort of pack how it would impact the commercial market in Maryland. And we haven't talked that much about the commercial market impact today, but sort of piggybacking on what Kathleen had said, is that generally, if there is a mandated benefit addition that in the commercial market, that we sort of do a cost analysis with the MHCC. And if we get to that level of recommendation, I would hope that we might be able to add Ben or somebody from the MHCC team to be able to give us sort of a high level sort of impact on premium for folks in the commercial market as we move forward. But we are certainly willing to take anything that Aaliyah can provide and run it up the flagpoles at the individual companies. So nice to see you all in August. I know it's rare.
I did get a spreadsheet from Aaliyah this morning. I have not had a chance to look at it myself, and I don't know if it's something that she intended to be circulated only among the work group or posted.
Well, Mary, when you discover, I'm happy to send it around.
Well, that's fine. And hopefully we will get that. I'll get that straightened out soon. I thought I saw her name earlier, but perhaps she had to drop off. But thank you. We appreciate your participation. And I know that, yes, it is August. And our next meeting, I believe, is in 2 weeks, which is also August. But I'm taking my vacation in September. So there you go. Anyway, I am not seeing additional hands up. Do we have any other comments for today?
Mary, this is Magali again. I believe that I speak for Aaliyah that it's okay to share because I had a conversation with her, and Matthew, that was her intent, was to provide you with all of us here at the CPT and also what's happening in other states. Just to give you a little bit of background, I'm not saying again that we have to do it the same way, but in other states, the way that gave to this bill that was introduced, that gave birth to this MIA group, was what has happened in other states, particularly Washington State. So part of the trajectory that was taken was really working with the Insurance Commission in that particular state to create what at that time was called a parity, or creating equality in terms of all the health plans providing beneficiaries with similar benefits and similar services. So the way that came was a bill was passed in Washington State requiring and really guiding the health plans to include pharmacists as providers, following, like I said, I'm not talking about different, credential, all of that, but to pay for some of these services and to follow similar to the medical model with the CPT codes that I alluded. So she shared with you some of those codes, some of the definitions, that kind of stuff. That's in the spreadsheet because it's actually happening in Washington State. I was hoping that Mindy could speak, but I think she may not have access to a microphone, but she has experience nationwide where this has been done. Again, in Florida is something that is being done. In Colorado just passed a similar bill that we introduced. In California, like Nikki State, many Medicaid programs across the nation have added these services. So that was the intent that we had with the legislation, again, following, getting ourselves apart with other states, again, because we strongly believe that the benefits to the beneficiaries outweigh what we might consider, some of the challenges to make this happen. And we provided, and I encourage you guys to look at some of the documents, we provided evidence or studies that have been done looking at, evidence. Does it matter? Does it work? What happens when these services are made available to beneficiaries? And we have plenty of data and evidence that shows that it improves care. So I think our ask is that the health plans and Medicaid really open mind to look at, is this something that your beneficiaries will benefit from? That it really makes sense to include and have access to these services. So I just wanted to outline that really sets the stage. Mindy, I think now you can speak.
Yes, I also want to note that Kyle Robb has his hand up. Craig, if you can move him to a panelist.
Yes, I can.
Thank you. And Mindy?
I'll just add to Magali's comments and the comments that have been stated that to my knowledge, as of 2022, there are 18 states that recognize pharmacists as providers. And yes, related to the Health Commission, the involvement of the Health Commission in partnership with the Medicaid department is essential, and even from setting up the legislative process, because provider parity legislation or fixes to the insurance rules, such as in Washington, was necessary in order for pharmacists to be added as a provider, so that the insurance and health plans could contract with the pharmacists as providers. So both in commercial and Medicaid across the country, there is these models are part of legislation has happened across the country, and I think there was 8 other states that are working on moving this process forward, as is Maryland. So that's all.
Okay. Thank you.
Confirm.
I do want to remind everyone we are focused on Maryland law here. And in the insurance article, there are different definitions of healthcare provider depending on what the law is addressing. And for many of them, we would consider pharmacies or pharmacists depending on the definition being used to be healthcare providers. And there are services that are within the scope of practice for pharmacists, as already laid out in the insurance article. So I think one thing to think about is, what is it specific to Maryland law that you would request? So, okay. So Kyle, Rob, you had your hand up.
Thank you so much to everybody in the work group for allowing me to make comments. My name is Kyle Robb. I am the Director of State Policy and Advocacy for the American Society of Health System Pharmacists and a Maryland resident and Maryland licensed pharmacist to boot. I wanted to provide a quick comment just to address the question in the agenda, specifically whether a change is required to the medical assistance program to potentially eliminate any barriers to pharmacist reimbursement. There are at least approximately 15 to 20 states, I can provide documentation of this as well, that have established pharmacists as other licensed practitioners for any service that's within the pharmacist scope of practice within their Medicaid state plan. So the other licensed practitioner designation is a designation given to all non-physician practitioners or potentially non-physician practitioners to allow them to independently bill for services. Currently under Maryland law, Maryland Senate Bill 363 that was passed in 2017 for pharmacists prescribing of contraceptives required the medical assistance program to cover services, assessment and evaluation services related to contraceptive prescribing. So the medical assistance program had submitted and had approved a state plan amendment that created designation of pharmacist prescribers. And it outlines certain reimbursable services, including contraceptive prescribing, that pharmacists can be reimbursed for. However, the current Medicaid state plan in Maryland does not afford for the potential reimbursement for anything within the pharmacist scope of practice. And it should be mentioned that state plan amendments establish eligibility for reimbursement rather than an actual requirement for reimbursement. But it is important that pharmacists be considered other licensed practitioners, potentially for anything within their scope of practice. So when we do have bills like the 2017 contraceptive prescribing bill, which was SB 363, I think someone requested a number. And then as well, this year in 2022, we had a tobacco cessation prescribing bill that expanded pharmacists' ability to provide tobacco cessation services. When the legislator passes these bills, we then have a payment mechanism. We have a eligibility criteria mechanism available to establish payment through the medical assistance program, because when the legislator passes these bills, their intent is to increase patients' access to these services. And if we don't create accompanying payment mechanisms or reimbursement pathways, then the actual implementation and patients' ability to access these services doesn't end up happening in the way the legislator may have intended. Another example of this is COVID-19 related services. I know there was a state plan amendment to expand pharmacist reimbursement for COVID-19 related vaccination, but the state plan does not specifically delineate pharmacist provided COVID-19 therapeutics, which again is very important in the context of pharmacists being able to prescribe Paxlovid. Again, the point of making Paxlovid available through pharmacists is to reduce the potential for hospitalizations and more expensive levels of care, and to allow patients to have easier access to COVID-19 therapies. So all of this is necessary. And I will also mention too as well, the current Medicaid state plan requires pharmacists to register with a pharmacy, and that reimbursement go through a pharmacy. That isn't necessarily inclusive of pharmacists who do not practice in traditional community pharmacy environments, such as pharmacists that practice within a health system clinic or within a long-term care facility, or other locations that we wouldn't necessarily associate with typical outpatient retail pharmacies. Those pharmacists might not have a reimbursement pathway for services. Thank you everyone for listening to my comments.
So Mary, if I could make just two comments.
Sure.
So Kyle, just within Maryland, we, when you do a state plan amendment and the fee for service program, it's any willing provider. Our MCOs have ability to do their individual contracting in their networks. Secondly, when you submit a state plan, you also have to have and submit your fiscal cost estimates, so the federal government knows it's going to cost on the federal side as well as the state side. And we generally don't submit state plan amendments that we don't anticipate implementing. So we like to do it again for a service that we have the budget for. Contraceptives is a perfect example where we have the budget for, then we make the change within the state plan to allow it.
Okay, thank you for that. And we are at noon. So I think there's about 30 seconds if someone has something to say that they really want to get in. But we are ready to adjourn, and I thank you all for attending today, and we will meet again in a couple of weeks for the next couple of topics.
Thank you, Mary.
Thank you.
Mary.